We're connecting. Success. Wonderful.
Hello.
Hello. Good morning.
How are you?
I am doing great. Happy for this opportunity. How are you doing?
I'm doing well. Also really excited for this.
Yes. So before we jump into the questions, I want to give everybody a little bit of information on your background. So Dr. Melissa Stendahl, she's a physical therapist, a doctorate of physical therapy, and you have completed your CAP, OB. So could you tell us just a little bit about what that is?
Yes, so that stands for Certificate of Achievement in Prenatal and Postpartum Physical Therapy, and it's awarded by the American Physical Therapy Association. So it's indicating that I've gone through a study track as well as testing and patient clinical practice with specific techniques for prenatal and postpartum care. It's a population that I'm familiar with working with and have focused in on a little bit. So
Yes, I'm loving your posts. I mean, the one on birth positions, I was like, oh my word, everybody needs to see this. Everybody needs to know this. And so a lot of the information that you're going to discuss today, you have sources on, and you've shared the sources with me. So if anybody is interested in specifically finding out where we're getting this information, Dr. Stendahl, Melissa has references if you want them. So, all right, you ready to just jump in and get going?
Yes.
Okay.
I wrote down some of the questions. Are you going to tell me them?
I'll kind of be the facilitator there.
Okay.
So tell me a little bit about the role of a physical therapist in labor and delivery, because it's a new concept that people probably aren't that familiar with.
Yes. The coursework that I took, the instructor actually was also a certified doula. And so there's the potential for PTs to actually be in the delivery room with laboring and delivering people, although it may cross over with other roles of other professionals. So most PTs that work with this population will include preparation for labor and delivery in prenatal physical therapy. So the prenatal or the pregnant patient may have symptoms that they would like treated, or maybe they don't have any symptoms, everything's going really well, but we can still do a lot of prep work to prevent symptoms, to kind of work with the person as their body continues to change and the pregnancy progresses, to maintain their level of activity and their health and fitness and their comfort level, and then prepare to prevent injury during childbirth, and also work on an early postpartum plan so that the person knows what to do within the weeks before they may see another therapist or even go to their OB for that 6-week check to get started on proper recovery.
Awesome. Excellent. Okay, so tell me a little bit about what are some of the types of injuries that we could see during labor and delivery.
So some of the more common ones with symptoms postpartum would be SI joint or pubic symphysis pain or injury. And let me grab my model.
Good. I was hoping you had one. I have a backup if you don't.
I have one, yes. So,
there we go.
The pubic symphysis is in the, magnetic parts.
The pelvic floor fell.
Oh no, this will not happen to you, okay? Pubic symphysis is in the front, so it's actually this little joint space. If you were to feel your belly and get to the hard bony part, that's that area. And in the back, the SI joints are the interface between the side pelvis and the sacrum. So it's like the butt bone or that hard bony area there. So if someone has like right or left sided low back pain, it's often in that SI joint area. So do see a lot of patients who have issues with pain or feelings of instability related to that. Occasionally, maybe a little joint separation, which we need to rehab for feeling better and secure and stable when you walk, especially position changes in walking is the most symptomatic for people. So like getting out of bed, lunging down to pick something up, handling the child, or sit to stand and then walking. So, and sometimes that pain can start during pregnancy, but sometimes it happens from maybe the position of the delivery or lack of mobility during delivery, or exacerbation of pain that was already there. So we want to consider ways to minimize strain to those areas during delivery. Also, abdominal wall, working abdominal wall, and then perineal tearing. Since we're talking about actual birth positions, this won't be quite as relevant to cesarean births, although any woman who pushed, if it wasn't a planned cesarean, there may be some of the same injury types. So for sure, still relevant. And then again, like I said, perineal tearing or episiotomy and any overstretching or lack of connection with the abdominal wall would be relevant to this too. So that's the main thing.
Yep.
Sometimes also tailbone pain, sometimes tailbone dislocation, and sometimes hip or knee injury.
Yes.
So there can be extreme positions of knee into chest or prolonged positions of knee into chest that can affect pre-existing hip issues. So if you already have a labral tear, if you already have hip impingement, if you already have knee pain, the strain of those positions can result in pain after delivery.
Very good. So what helps to prevent perineal tearing? So is there a position that you would specifically recommend and say, okay, this is the best position to avoid? I mean, of course we can't guarantee, right?
Sure. So a lot of patients already know about perineal massage and stretching. The studies we have right now are mixed reviews on how helpful that is. It's more about familiarity with the stretch sensation, but positions and how a person pushes actually has a pretty good impact on perineal tearing. So sideline, I'm going to talk about sideline or emphasize sideline a lot in this, is one of those positions that's helpful. And hands and knees, or quadruped is what that's called, hands and knees positions. Because what that does is allows opening of the pelvic outlet. So this bottom portion, a widening, which is the area, the final area the baby has to pass through. We want that area to widen and not be narrow, therefore creating more strain into the tissues. Also, how the pushing is done. So that's a huge factor. I don't know information like statistics to show how influential, but we do know that it's like anything that stretches. If you go from no stretch to really intense stretch quickly, the tissues don't have enough time to change. So what you want to do is have nice progressive and gradual pushing or descending of the baby through the birth canal, so that the perineum and the vaginal wall has time to stretch and not end up tearing from kind of going too fast. So sideline, again, is one of those positions where it can actually be helpful for maybe reducing too quick progressing push phase, because if a woman is upright for that, that's like extra assistance, which a lot of birthing moms need. But if it's actually too fast, then you can slow it down a little with a sideline while also keeping the front and back of the pelvis open.
So basically, if you're lying on your back, the SI joint has no ability. You're not allowing the opening there. So it's in a kind of a rigid stop there.
Pretty much, yes. So the back and front of the pelvis, this is the front side view. We want these areas, the sacrum, the tailbone, to be able to move out of the way, and we don't want too much movement of the pubic symphysis. We do want these portions to move, but not like a separation here. So laying on the back or in a reclined, semi-reclined position, this back side of the skeleton is anchored down. It's not free to move. This area is very free to move. And then the outlet is also affected by the position of the hip. And again, usually the legs will be splayed open, knees into chest. So it's a lot of, you have to push more. This area isn't available to move. Go on the side. Now these areas can move. And with gradual pushing and gradual emergence of the baby through the birth canal, that can definitely help prevent the incidence of tearing.
Good. So basically, if you're on your back, the front may have the potential or strong potential of actually moving too much, or so because the back side isn't getting that mobility, and so something's got to give, right?
Exactly.
Okay, good.
Exactly.
Excellent. That's a very helpful explanation. I'm learning a lot, so thank you.
Good.
Okay, so what if I have an epidural? I saw this as a recurring question. So
Absolutely.
what are the options in terms of positions?
Actually, almost everything. That answer is not what you're going to probably hear in a hospital setting. It's beyond the scope of what a lot of practitioners are taught, like how to deliver. For example, in school, it's probably easier to have the dummy or the model laying on the back because OBGYNs are wanting to make sure everyone is safe and surviving the birth. And if there's an emergency or a special circumstance, that is a good position for them to work on. So with the epidural, that's kind of the standard position to go in. But I would recommend for an epidural some of the easiest to achieve with a little assistance is sideline again.
Uh-huh.
Sideline is very helpful for rotating a baby, for increasing mobility of the pelvis. Easy to get into in the bed. Someone can just help rotate the patient. But also, it's still possible to get into semi-upright positions kneeling in the bed too. Again, it depends on how well the team is willing to assist you. The beds are mobile, right? Like the head of the bed can move, the height of the bed can move. So if the birthing person can get turned or rotated onto hands and knees or sideline, the bed can then be moved and change the position of the pelvis.
So that's a conversation really to have in advance with your birth provider and the facility that you're going to be, delivering at. What are my choices? What are my choices? So that you're not going into labor with a certain expectation. I want this. And they say, no, you can't. I want to jump back to the sideline. There's a question here. So she birthed sideline last time, and it was nearly impossible to hold the upper leg for a long period of time. Do you have any advice on a good way to prop that up?
Someone else should hold your leg.
Don't do
this is where, yes, this is where a birth partner, whether it's another parent or a friend, the doula, whoever you have there, can be responsible for holding the limb. It depends, again, what the main medical provider, like if it's a midwife or OBGYN, what their preference is and where they will allow people to assist. But if everything is proceeding normally and healthy, there's no special considerations, it should be fine to have somebody assisting the leg or propping the leg up. Sideline, again, can be easy for that because in sideline, you only need one leg propped up. Mm-hmm. And you can also have it propped on like a peanut ball or bolster or pillows or something like that, kind of out of the way.
So the upper leg would be kind of forward of the body.
Yes, I can hop on I don't know if you can see the table.
I think we can. Let's see. I can see pillows. Try it. Let's try it.
Let me see. Let me get creative here. I wish I had a assistant for this.
Someday.
I thought about recruiting somebody. So, okay, this will work.
Yeah, that's
so
great.
So here I am laying down, and the top leg, the bottom leg is kind of in line with my body. The top leg would be resting on something here. And then the pelvis is available for access here. So the other direction, let's show it this way. Top legs forward, out of the way, resting on something, or someone's holding it.
Uh-huh.
Someone's holding my leg, and then no problems. Everything's free here.
Yep. I would think that even with someone holding it, if it's going on for several hours, that person is probably going to fatigue some too. So having something like a peanut ball or something to bolster it up would be helpful.
Sure. And also position changes. So it really shouldn't be necessary to be in the same position for hours. That's not recommended with with or without epidural. It's recommended that the person is rotated from one side lying, then maybe to seated, either forward lean or some kind of like upright position, and then maybe rotated onto the other side. That also helps with the position of the baby. The baby has specific movements to make to rotate and descend. And so continued mobility through the phases of labor is considered favorable and, again, helpful for delaying things, helpful for preventing tears, and keeping the pelvis, allowing the pelvis to go ahead and move as it needs to, depending on the station of the baby in the pelvis.
Okay. Mariana Foster gave a couple comments here. So she is a nurse, and she's finding that Sideline is less effective, especially with less effective for pushing. So how can we use Sideline and still have effective pushing with patients that have epidural?
Got it. Okay, so I would love more information on that too, on the other elements going on in those scenarios. So I'm going to do my best to answer what I know, keeping in mind too that I'm not in the delivery room with patients. So, there may be other therapists who specialize in this could possibly have some of these answers too. So
if anybody wants to leave comments, feel free.
Yes, please. So something that may be helpful to get a better recruitment of musculature for pushing is to make sure that there's somebody at the foot of the upper leg for the mom to push the foot into.
Okay, that makes sense.
So, yep, because in other effective positions like squatting or kneeling or half kneeling, something like that. Yeah, there's pressure into the ground from the limb. Sideline, there's none. And even on laying on the back, like what's a more common position now, a lot of times there's someone holding, or the mom holding the back of the knees, or someone pushing, they're pushing with their foot down into something. Yes. So it's possible that having someone at the foot would increase the efficiency of that.
Good.
And I see the comment has to do with an epidural. So yeah.
Feeling it as well, but still having some kind of support there might potentially help. So.
Right. And with the epidural, it depends, I think, too, on the intensity of the epidural. If it's, how much sensation, motor control the mom has.
Yeah.
Yeah. So kind of giving something to push against if that's possible. Or with an epidural, maybe it's not as effective. So ultimately the baby needs to come out. So you got to kind of do what needs to happen.
If it's not working.
Yeah.
Mm-hmm.
Exactly.
Okay, good. So what is push prep?
Push prep is learning.
Tell me about that.
Yes, that is learning how to properly use the pelvic floor, the abdominal muscles, and the breath to push properly.
Okay. So
that involves learning pelvic floor muscle awareness. Do you actually do a kegel properly? And do you do a bulge or a bear down properly? Sometimes I find that somebody thinks they're bearing down and they're actually kegeling instead.
Yeah.
So it's like the opposite. It's holding tight instead of relaxing. So push prep involves making sure that there's good awareness and control of the pelvic floor muscles, that the breath can be used to help with pushing properly, and to basically practice that ahead of time so that you know what to do.
Do you have any tools or resources that we could send people to say, okay, this is where you can learn? Would you say go to a pelvic therapist for that?
For sure. So hopefully in your local area you can go in person. That's most effective because then you get a one-on-one evaluation. Or if you can attend a push prep class, at least in New York City where I am, there are several PTs, OTs, and doulas who offer training courses on specifically push prep or childbirth prep that includes that. And so if you can go in person to like a coursework or something like that, that would be great. But individual evaluation from a pelvic health specialist would be great, because then you can get an actual pelvic floor evaluation and individualized feedback. And the cues, everyone responds different to different types of cues. So I might use an elevator analogy for one person and a like a blueberry analogy for the next.
Exactly.
So.
Exactly. So just kind of a quick recap. I think most of you understand the anatomy of the pelvic floor, but it actually kind of wraps around the vagina. So when we want a baby to come out, we don't want those muscles squeezing. We want the muscles, we don't want them squeezing. We want them opening so that the baby can exit. That's the song. Yeah.
Yes.
And then effectively connecting that sensation with your body and coordinating it with your breathing.
Yes, exactly.
Okay, so what will cause a diastasis during pregnancy or delivery? Why does it happen?
Well, it happens to everybody who is pregnant because the abdomen stretches. So
It has to expand.
It has to. And we're talking about the tissue in between the two sheets of six-pack muscles. So we all have six packs. Whether or not you see them is a different
muscles
topic.
Are there. The muscles are
They're in there. And so there's going to be a stretch. Everyone has it. And then that little stretch goes back generally after pregnancy is over. A little bit, might need a little bit of help the more children you have, or just if you seem to have more weakness or, signs of like air pressure or bloating afterwards. So that's something that gets assessed in a postpartum evaluation. And again, there's really no prevention. So we just have to change. It's going to happen. There is prevention for proper rehab and regaining the connection and the tension needed there. But I think changing our mindset on that is important, to not fear it, not worry about it. Just know that there are things you can do to properly prepare and prevent it being a prolonged issue or feeding into issues with low back pain and pelvic pain.
Mm-hmm. And then get a postpartum assessment, really.
Please. Yeah, I really just recommend a prenatal and a postpartum assessment for every person, just to know kind of what you're predisposed to or what you thought was normal and actually isn't. Mm. We all have to rehab from pregnancy. It's just, and that should be normal. We don't have kind of a standardized care for that in the U.S.
Not here in the U.S. So just a quick timeout. You have a clinic, you're at a clinic in New York. What is your clinic's name?
It's just with my name, Stendahl Physical Therapy. So good. I have location in Brooklyn, primary location in Brooklyn. Yep.
Okay. So if you guys are in the Brooklyn area, look you up.
Yes.
Excellent. Okay. So if I have a planned cesarean, do I still need prenatal PT? And why do I need to know all this stuff if I'm having a C-section, basically?
Yes. So not all C-sections are planned. So I think that even if you have been told you may need one, maybe there are some conditions where the OB has talked to you about that potential, I would still prepare for pushing, because most likely you'll be given a chance to birth vaginally and, have the cesarean if that's needed. If it is planned, then you will not have the full effects of pushing and the vaginal birth, but there's still pressure and mechanical changes, physiology changes with a pregnancy, period. So a lot of the postpartum issues are the exact same no matter what birth. You will also have scar tissue at the abdomen.
Yes.
That has a huge effect on how you use your body, how things move, soft tissue mobility, muscle recruitment. So still relevant. We just may not have to talk about all of the same things. Right. Probably not birth positions.
Yeah, exactly. Okay, is this the same information I'd get in a childbirth class or with my doula?
To a small degree, but generally the answer to that is no. The childbirth class covers a lot of stuff, including diaper changes and breastfeeding tactics and things like that. So physical therapy, prenatal prep is going to be really targeted on your body, injury prevention, pain management, treating symptoms you currently have, and exercise, like how you can maintain mobility and exercise. And then doula may have a lot more crossover, but that kind of depends on the doula's training and how much hands-on techniques they do, what types of techniques. So many doulas have understanding of, well, they all have understanding of the birth process and the physiology of birth, like what the baby and mom are doing together, but they may or may not do similar hands-on techniques for pelvic mobility and things like that.
And my understanding is that doulas are not touching genitals. Like they're not, so you're really not going to get a pelvic health assessment unless you go to, So we want to assess the pelvic floor and the hand-on. So with a pelvic floor PT or a pelvic health, women's health therapist, you're going to get that hands-on assessment of your tissue.
Yeah. If you consent to that, yes.
We are advocating everything. We want as much intervention as you can. So a doula, childbirth class, and pelvic health PT, that would be perfect.
That would be, I think, ideal.
Don't forget the birth providers.
Yeah, of course. That's number one.
And then you have the facility too, and learning all that. So there's a lot of factors that go into this. So how soon after delivery can I start exercises?
Depends on how you define exercise. So day one is my official answer, but those exercises are going to be breathing techniques and reconnecting with how to use the pelvic floor. So that goes back to what you probably would have learned prenatally if you saw me, using visualization techniques, even if your sensation and strength is altered, to try to do some muscle activity with your abdomen and pelvic floor. And definitely will count exercise as being how you handle your infant, because there's going to be weight there, whether it's 6 pounds or 10 pounds or whatever. You have to immediately start handling the baby. You may have other children, other household activities you need to manage. You have to be able to do things safely and with good body mechanics just around the house. So we can do exercises for those.
Mm-hmm. Good.
So day one.
Yes, I agree completely. Something that I love and that helps me really well, a PT tech actually recommended this to me with my first pregnancy. And she said, Jeanice, every time you're feeding the baby, every time you're sitting down, whether you're breastfeeding or bottle feeding, every time you're feeding the baby, work on breathing and work on connecting with your pelvic floor. Try to squeeze and pull your belly button to your spine. So that was very helpful to me, like to have a quiet time.
Sure.
Now, at the very beginning, when you're first figuring out breastfeeding, well, that may not be the best thing.
So hard.
But once things settle down and you're into a good rhythm, that seems to be a quiet time that I could also do some good exercises. Yeah. I'm going to jump to one of the other questions here, prolapse, because that came up multiple times.
I did. I saw that.
Yeah. Is there a position that you would recommend or that we should try to avoid to prevent prolapse or further descent?
I didn't find much. I don't think there's much out there on positions with prolapse yet. If someone knows otherwise, please chime in. But that is going to be more about how you push and how long you're pushing. So for prolapse prevention, we're talking things like delaying the pushing as much as possible. So laboring down or just letting, again, the baby needs to be at the right station, basically at the pelvic floor before there is pushing. So whether that's directed, which is usually what happens with an epidural, because the mother may have, not full sensation, or maybe she has some sensations of pressure or whatever. But directed pushing is where someone's coaching you in it, and then mother-led pushing is when you're kind of just rolling with it when you feel the urge. So uninhibited, we would all have this fetal ejection reflex, which is triggered when the head is at the pelvic floor, which triggers the response to expel the baby. So, so we actually have an automatic response for that minimizes how long and hard we have to push on top of that. So waiting until there's true urgency to push, waiting until the baby's at the right station in the pelvis, which the medical provider should be able to guide you on based on feeling where the head is, will help with prolapse. Additionally, there can be assistive positions like sideline or hands and knees. So sideline and hands and knees is kind of the universal, almost fine for everybody, as long as you can get into those positions that are helpful. Squatting, I'll say one thing on squatting. Squatting, like being in a full squat, is does have a little bit increased risk of perineal tearing. And if you already had prolapse condition coming into it, I will say subjectively, I don't know, how much that may contribute to that, because it's a very open position and like weight's fully down, feet are in the ground. It's a very powerful position. So at that point, that doesn't mean there's going to be a tear or exacerbated prolapse. Again, I'm going to default to how the breath is used, how fast the baby comes out, making sure there's a gradual crowning and opening through the vagina, and then again prolonged if you've been pushing for a really, really long time. So breath work is relevant to that too.
That's good. And I would suggest also that you talk with your birth provider about your concerns with prolapse and see if they have any, recommendations as well. I spoke with one OB, and sometimes she will actually support the perineum if possible as the baby's exiting. So that's great. That's giving some, but that's not always possible. Sometimes we need to open it up to allow the baby to come out. So
it's true. I actually have a note on this. Let's see.
Yeah, definitely have a discussion with your birth provider.
Yes.
And perineal massage, generally starting at 35 weeks to help teach the muscles how to relax and help stretch the tissue, may be helpful. It's definitely not unhelpful, but always clear it with your birth provider. Did you have anything to add on this?
I think I got it. So the note you made about the talking to the birth provider ahead of time, I think is very helpful, and something that goes really kind of by the wayside too often, because a lot of times that care provider simply won't know what you're dealing with. So if you did get some prenatal assessment and can kind of get some notes from the physical therapist or occupational therapist who's seeing you, then you can bring that information to the care provider and say, hey, I've been dealing with this, or I already have this, and I really care about preserving that. And sometimes that's all that's needed. They just didn't know that you were dealing with something, or they're not the person who would treat that, so they weren't thinking to consider that.
Yeah, and I had a tailbone fracture last time, or I have this really bad SI pain, I have a hip labral tear, or whatever. Just being upfront and discussing those things. That's good.
Right.
I'm going to put a plug in for, it's called the Informed Birth Class at Mommy Labor Nurse has it. It's an online self-paced class. And I think it gives you a lot, it's very inexpensive, and it gives you a lot of framework about what all these things are, and a really good starting point, even in terms of discussing with your birth provider. So check that out. I'm seeing some weird connectivity. Can you hear me? Hello? Oh, no. Oh, we lost her. I'm going to tag for the birth class that I was referencing at mommy dot labor nurse, and we'll see if Melissa can join us. Oh, you can hear me. Yay! That's my sister. Ha! So I'm not just speaking alone. Well, thank you guys for joining us. I'm not sure if, oh, good. Here's Melissa coming back there. Gonna try to join again. Hello. Let's see if we can reconnect. Thank you guys for being patient with technology. It's amazing when it works. Okay, yay, we're back together. It just kind of, your face just froze for a while. I had left, or I felt like I was floating in space alone. So good. I'm so glad you're back.
It turned off due to heat. I don't know what to do for that, but I just, I'm back. I'm so sorry, everybody.
It's okay. No, I learned something with technology every day, and I'm still learning. So
I'm turning the fan on in here, maybe.
Okay. How soon would you say after delivery would you attend postpartum PT? How soon do you like to see new birth parents in?
As soon as you want to come in. I think you need to do what's safe for you to leave the house if you had a cesarean, or if you're really dealing with a lot of discomfort or any kind of healing, excessive bleeding. Please do what your physician says. I typically don't see people until 6 to 8 weeks, just because logistically I think it can be hard to get out of the house or to manage to come in. But within those first 2 months is ideal. The sooner the better.
Yeah. And there are also, this is I think a really cool concept. There's therapists that are going out and doing in-home pelvic health and women's health assessments postpartum.
Yes.
So I see that growing, and if I were a new birthing parent, I think I might sign up for that. Hey, come see me. Then I don't have to get everybody dressed. I don't have to get everybody, especially if you have multiple children, and just getting out of the house is a big deal.
Sure. The advantage at home too is that the therapist can work with you in your setup. So at your bed height, doing, touching, reaching, the things that you need to do. So that can definitely be helpful.
I think, are you turning off the fan?
Yes.
Okay.
I don't know, technology.
Thank you for your feedback. We appreciate it. Okay. Let me go back to hip position. So if you had a labral tear, what would be the ideal position, would you say, for labor?
Yes, I'm glad you brought that up. That was a question too. So if you already have hip issues, and the same actually goes for knee. Can everybody hear me okay?
I can hear you. It's a little bit like you're in a well, but it's not bad. I can hear you.
Okay.
Is everybody else, is it okay out there?
I'm going to get close.
Okay.
So hip and knee is kind of the same. So that position of knees into chest, legs splayed open, knees tucked in, being in that position for a long time, or just being in the end range of that, like really far tucked in, is considered not ideal or not helpful for that. Some easy solutions, like let's say you want to be in a position like that, or your care provider wants you like that, just getting a break out of it. So go back to the birth partner, another parent, friend, whoever else is with you, doula, having that person, again, is something you bring up ahead of time, like, hey, I have this hip issue, or I have this knee consideration, and then just simply moving the limb. Whether or not you have an epidural, someone can hold that leg and stretch it, move it in and out, back and forth, just changing the angle. Mm-hmm. So basically, you don't want an unsupported knee, a knee that's really like in or out, or hips that are really tight in. Some people already know they can't have knee into chest very deep already. They've always had, or they had a prior injury
right.
That they're dealing with for the hip. So just don't even go there to begin with, or take breaks from it.
Yeah. So that's a really good point, though, like understanding your body and knowing that your body is generally going to be going into some of these positions. So even maybe simulate some of that at home in terms of putting your knees up to your chest. Can you do that comfortably? Do you need to start doing some stretching in advance?
Exactly.
Either preparing your body, or if you know that it's an injury and you can't do that position, talking about it and having a plan in advance. I think that's super.
Yeah, that's why we practice it prenatally. And then I also invite clients to bring a partner with them to actually practice those things, and make someone else responsible for all these little things that you're trying to remember for yourself.
Remember all of this.
Yeah, you will be busy. Make someone else responsible for remembering these things, because you might not even realize to ask, or you may not feel it. A lot of clients don't realize their hip or knee is being tweaked until afterwards. They're like, man, my hip's been aching for 6-7 weeks now. It's not going away. Because they felt all the other sensations, or they had some anesthesia. So definitely use a partner for that.
Yes, excellent. Very good. Are there different positions that can be used to help stall labor? So we want to put it off. We're not ready for the baby to come out. What position should we go into?
Mm-hmm. For stalling, sideline. A lot of the upright positions, gravity is kind of assisting in the speed. Or if the baby is like getting help positioning and descending, it can kind of go faster. I think more people need help with progressing it than stalling it. But if we do want some more time, we can go to the sideline, and then you can also talk to the your care provider about therapeutic rest using epidural for kind of like calming things down and allowing a woman to rest instead of like so much pushing. So
good. Excellent. Yeah. Okay, so this is a super one. You talked about this, the pubic symphysis some, but if we know that we have pubic symphysis pain and dysfunction going into labor, what is the best position and what should we try to avoid?
The best position is going to depend on a few things. There's more than one answer for best position. It's probably more useful to know what to avoid, and that again would be the back of the pelvis.
Yeah,
the back
remember,
of the spine.
Its rigid, it's not moving there.
Right. We don't want it clamped down. So this is a little more likely to cause tailbone injuries and pubic symphysis injuries because something's going to try to give when you don't have the ability of this portion to move out of the way.
That's beautiful. That's such a good explanation. Beautiful.
Trying to keep it a little simple.
Yeah.
There's a lot of detail and things to consider, but
that's good.
Bottom line is keep the back free.
Mm-hmm. Okay, and then something similar probably. What position should I avoid if I have sacroiliac joint pain?
Same thing. Just allow freedom of movement, and then try ahead of time. If you are going to be spending time in sideline, if you know that being on one side, like when you sleep, you probably already know this, that it bothers you, then getting help on that or knowing that ahead of time and avoiding that. Sacroiliac can also be influenced by the tension of the glute muscles. So some massage techniques during labor or just even before labor, just part of your plan, can help with relieving soft tissue tension to the SI region. I would also be prescribing some exercises to help with proper strengthening and stability. But again, with labor, the things that will relate labor and birth would be, again, that the back of that pelvis is open, so your sacrum can move the way it needs to. Sacrum is part of the SI joint, stands for sacroiliac.
Yeah, it's
and then that soft tissue stuff.
Yeah,
exactly.
So here's your joint. You have two sacroiliac joints, and then muscles cover all of this. Good. Okay, I think we can jump into some of the sticker questions. I think we covered a lot of them, but there's a few here. So why do you think that most moms give birth on their back? A facility
that
preference?
Has some it's a fun question. There's some historical context to that starting in like the 1800s. Initially, a lot of the interventions, including the laying on the back position, came about to try to help improve outcomes for abnormal or high-risk scenarios. Laying on the back, again, is most convenient for care providers for treating and addressing issues. And even if there's an epidural, sometimes for providing certain pressure into the perineum or vaginal area, which can be accessed well that way. And then as pain management came about, which actually dates back to like Queen Victoria, trying to kind of be feeling more comfortable, pain management strategies that involve either like twilight sleep, which we don't do that anymore, but it was like almost semi-consciousness. So really uninvolved, less involved.
Yeah. So you're not
gotta lay down.
Yeah.
Yeah. So there's that. And then now the modern epidural, which is a decrease in sensation and motor control of like the lower body. That's just, I think, kind of like an obvious position, like, oh, well, we would do that. But there are other options for, again, making sure the pelvis has full mobility. So
Good.
the answer why has to do more with kind of the evolution of interventions. And then the research we have is kind of still new. Like we're still finding out outcomes, how they're affected by certain prenatal treatments, certain things that happen in labor and delivery, and it's hard to do research on that. You know, you don't want to mess with, like, experiment with someone who's pregnant or delivering.
Yeah, like,
so we have to wait.
The outcome is bad, you know?
Right. So we have to wait and then collect this information and see how it relates, and then determine, okay, interventions are no good or they're great. So we're learning more and more all the time about, you know, whether or not, like, lying on the back makes sense. And then there's, again, talking to your care provider and your birth team and kind of questioning it and being like, well, I heard about this or that, or, well, I have this going on. Shouldn't we consider something else? Or I would like to consider other options. And then if you're allowed to move and you instinctually want to be on your back, go for it. You know, like, that's, if someone left you alone, you would still birth. If that's how you feel like being, then there's probably a good reason, because these sensations and the pain as messages to your body. So
good. I'm going to just encourage Orchard Merkel to direct message me, and we'll try to connect you with some resources to get you some help and some intervention. I can't guarantee anything, but we'll do our best to help you.
Yeah, definitely want more information.
Yeah, need more information. So, and she might have sent it to me via DM. I don't remember the specifics though.
Okay.
So I did want to jump back here with a high risk pregnancy. Well, and just a disclaimer, like, all of this is just general information. This is not specific medical information. You need to talk to your birth provider, your birth facility, and this is not meant to tell you exactly what to do. Right. General ideas and recommendations. So if they have a high risk pregnancy, are there any specific positions that you would advocate or try to stay away from? Does it make a difference with high risk?
I'm going to default that or defer that to the care provider. That person, it depends on the high risk.
There's
the high risk reason.
So many variables and factors involved.
Right. So there's probably going to be more monitoring with high risk, and there may be some consideration for mobility with the monitoring equipment. So just need to do what's the most safe. Keeping in mind that age above 35 is not biomechanically a high risk issue. That in and of itself, that's different, you know, than like placenta previa or preterm labor or something. Yeah.
Good. Okay. So we talked a little bit about breathing and the connection with the pelvic floor, but is there any specific breathing techniques that you would recommend? Do you want to do deep breathing? Do you want to do short breathing? You want to do a combination?
Got it. Mm-hmm. I think a combination makes sense. Those push prep classes might help to highlight, or from, if you have a doula, he or she probably knows some good options depending on what stage you're in, how you're coping. But generally, deeper breath or slower breaths is better. That helps our nervous system to calm down. It helps muscles relax.
And that's what we need. And we need the pelvic floor to open and relax.
We want to not feel like fight or flight, right? We want to be comfortable and confident in the birth scenario.
Very good.
I actually recommend that's like almost one of the best things you can do for injury prevention too, is that you've done whatever it takes ahead of time to be confident in your team, confident in your setup, to have an environment that you're comfortable with, whether that's like who's in there, the lights, the music, whatever, tools that you want to use. And then once it's going, like, roll with it and, you know, advocate if you really feel like something in the moment. But that will help a lot. That stress management ahead of time and during will help a lot with proper pelvic floor muscle relaxation and allowing your breath, like, to be more normal and deep instead of like fearful, holding breath, frightened. During pushing, holding the breath is not so much recommended anymore. Keeping the throat open, so in other words, breathing out or moaning, groaning, low tones as you push is very helpful, and helps with, again, preventing like pelvic floor tensioning.
We don't want to see the veins popping out and the eyes bulging.
No. Well, just think about the difference. You can even try this, right? Do like a high-pitched scream or hold your breath and strain. How does your body feel compared to if you like really blow out or if you like low moan? It's a very different sensation through the whole body. So
good. That's a good example. Okay, is there a best position for pushing a baby out that is sunny side up? Like,
yes, that was another big question, is occiput posterior or sunny side up. So what that means is the baby's head is against the back and the face is facing forward.
Okay.
We want it the other way around. So if that is the presentation, which again, the care provider would have to figure that out and figure out if that's what's going on, you can do a series of asymmetrical upright positions, like a half lunge or a half kneeling position.
Okay, because we're trying to rotate.
Yes. So if the baby is facing the back to the right, you want to open the right side.
Okay.
If the baby is facing the back to the head is on the back and to the left, then you would open the left side. If you're not sure, you can try both, alternating. And so that's achieved nicely with like a foot up on a footstool or the back of a chair. Let me see if you can see me again.
So yeah, let's go through one example of this. So if the baby, the head is on the back and it's rotated a little bit left, it's facing left, what would you do?
This is, so my foot's up on the table here. It doesn't have to be this high. It can be a step stool or a stair. Some women might be told go out in the hallway on the staircase, and I'm just holding into this position. You might have contractions in this position. This might be something you can do prior to the onset of labor to help with optimizing the position. So my left leg is up to open the left side pelvis.
Okay. Your right leg is up to open the left side.
Other way around.
Okay.
Whichever side, if it's occiput posterior or sunny side up left, my left leg goes up.
Okay. Okay.
Same thing if you can do that in side lying as well, where the left side would be
good.
You want to be opening the left side.
Okay. Excellent. Okay. How do you keep the baby's head from getting stuck? Well, we need an opening, right? So maybe try the sideline position to see if you get greater opening.
Right. Sideline
or hands and knees.
Up hands and knees is great. So this is actually relevant to the last question as well. So sunny side up and stuck is going to be a series of like pelvic rocks. You can be on hands and knees, sitting back onto your heels, swaying side to side. You can transition to positions where, again, one foot's up on a footstool. It's really about like stuck. Being truly stuck is one thing. Being simply not in a great position because you've been immobile is a whole other thing, and that's actually easy to address. You just move. So your care provider can help guide what positions those need to be. But again, since I'm not there and I'm not the expert in the delivery room, the two almost universally helpful positions that are also pretty friendly for hospital environments is side lying and hands and knees. So you can rock and sway. The pelvic floor is open, the sit bones are spread in those positions, and you can really do, keep everything available. With sideline, you may need to be rotated from side to side.
I think we got all the questions except this one, hamstring. So persistent high hamstring injury, what would you recommend for that? Yes.
So I thought of two things for that. One is to consider the influence that hamstring issue may have on the pelvis ahead of time.
Because it's attaching.
Exactly. So the hamstrings attach on the sit bone, which is part of your pelvis. So I'm guessing, educated guess, that the abnormal tension, whatever abnormal muscle activity of that hamstring is maybe pulling the pelvis into more of a tucked position, which we want to be maybe not tucked like during childbirth. So, and that sit bone needs to spread a bit as well during childbirth. So it may not be an issue because the natural cascade of events that happens with the body and with the fetus moving, a lot of times takes care of itself. But ahead of time, you could do some rehab work with, you're probably seeing a PT, to certainly try to normalize that as much as possible. Mm-hmm. And also figuring out maybe positions that don't work the hamstring. So a squat, I probably wouldn't do for a hamstring issue.
You're having to stabilize. You're having to stretch.
Yeah, you have to use the hamstring. Right. So I would do more things that involve, positions of rest for the leg, maybe more semi-lying down positions, or if you're kneeling or something like that, that's okay. But any kind of standing like through the ground, or if you're going up and down in and out of a position, probably avoiding more squatting or, things like that.
Yep. That's good. Great. That was amazing. I think we got everything. If you guys have any other questions or feedback, we'd love to hear from you. Melissa, Can
I add one thing?
Yes.
I thought this was important too for a lot of the facilitation of progressing labor. Keep in mind that upright positions may help the fetus descend and engage better with the pelvic floor. Okay. So again, the position, the position of the baby's head is part of the cues for the body to do the next thing. So it may just be that you need to alternate some time walking asymmetrical, like that stair lunging type of thing, and just getting into a seated position of some sort if you have been laying down. So I thought that was relevant and something important. So